Welcome to section 9.7, where we're going to talk about some features and anatomy of selected joints. We're going to start off moving from superior portions on the body down to the inferior end of our body. So we'll start off with the temporomandibular joint, which is going to be when the head of the mandible, which you can see a little bit better over here, is going to articulate with our temporal bone, specifically at that mandibular fossa of the temporal bone. This is the only mobile joint between the bones in our skull, and we also have this loose articular capsule surrounding this joint. It is going to be able to promote an extensive range of motion here, and if you look between these two bones, we have this very special articular disc in here. This is just a thick pad of fibrocartilage that is going to divide the synovial cavity into two separate chambers. So you can see one in the top and one in blue at the bottom. So when we look at this temporomandibular joints, we can also find that we have two special ligaments in here. We have our sphenomandibular ligament, which takes place right over here. It's a little shaded or faded in here because it's going onto the internal surface of the mandible. So it's extending anteriorly and inferiorly from the sphenoid bone, which isn't really pictured in this view, but then it attaches to the mandible inferiorly. Our other ligament is the temporomandibular ligament here. It's extending inferiorly and posteriorly from the articular tubercle to the mandible. And let's talk about some of the movements that take place at the TMJ. We're going to be able to see that we have it serving as a hinge joint. It's also going to be able to glide anteriorly and has some pivot movements. So it's functioning like a hinge when we have that depression, which we see over here. And then when we bring it back up, that's elevation. And then we have that gliding motion that can take place, such as protracting or moving the jaw side to side to grind our teeth. And that is also known as lateral excursion. And let's talk about some TMJ disorders as well. The most common is due to an alteration in those ligaments we talked about that help to secure the joint. And the articular disc can be forced out of its normal position. So I apologize, this image is a little bit blurry in here, but you could see the normal position in which this disc sits when the jaw is closed. And then when we open it, it kind of pivots anteriorly. And then if we have disc displacement with our jaw clicking, then you might have that disc sit more anteriorly in that closed position. And then when we open, it's just kind of staying in that region. And when we have disc displacement with the jaw locking, it is going to slide anteriorly. And then when we open our jaw, you'll see that we have that disc shift a bit more anteriorly than we would like. And then the head of that mandible is sitting just posterior to that disc. And so you might have pain in the joint, also within the paranasal sinuses, the tympanic membrane that is better known as our eardrum within our ear, within our oral cavity, eyes, and teeth as well. Now let's move into our shoulder joint. We have our sternoclavicular joint, which is going to be a saddle joint. So you can kind of see that saddle shape a little bit better here where the bone and the ligament has been taken out, where we are seeing the manubrium and the sternal end of the clavicle come into contact with one another. This is another one of those special joints in which we can see an articular disc placed in between the two articulating bones. And once again, we're going to see that it partitions that joint into two cavities. So here's the inferior cavity and the superior cavity. The movements that will have take place over here are elevation and depression. So if you were to shrug your shoulders, that would allow elevation, and then bringing them back down is depression. And then circumduction of the clavicle is also possible as we're moving our shoulder joint around. The stability is provided by fibers and ligaments here, and this makes the specific joint very stable and difficult to dislocate. Now, if we look in the shoulder more, we can see our acromioclavicular joint. This is an illustration, whereas this is a cadaveric view over here where we see the ligament over the actual joint. And this is a plane joint. So if you think of how the shape of the acromial end of the clavicle looks and the acromion itself, you'll notice that they both have those flat surfaces. So they're coming together to form that plane joint. This is another joint where we're going to have a fibrocartilaginous articular disc in here within our joint cavity. And also the joint capsule is going to be strengthened by this acromioclavicular ligament that we pointed out earlier. And our clavicle is bound to coracoid process here, or in our illustration, it's over here, by the coracoclavicular ligament. So you can see this ligament in here. And this is, in the situation where this is torn, the acromion and the clavicle no longer align, and we start to see a shoulder separation take place. Now for our glenohumeral joint, or better known as our shoulder joint. This is a ball and socket joint that's going to be formed by the head of the humerus and that glenoid cavity of the scapula, and it's going to permit the greatest range of motion that we'll see in any joint of the body, which also makes it the least stable. So it's the most frequently dislocated. Our fibrocartilage that we're going to find surrounding the glenoid tubercle is going to be known as the glenoid labrum, which I think we're going to see better in another illustration. And also in this region, we'll see abundant bursa surrounding this joint. And this helps to decrease the friction where we're going to have tendons and muscles extend across the capsule. So here I want to point out, even though it's not identified in the illustration, but here's where we're going to find that labrum. It's kind of like a cartilage type of tissue that deepens the socket here. And within our shoulder joint, we're also going to have some ligaments that are going to support this area. So we'll start off with our coracoacromial ligament. And what's nice about all of these ligaments is that it's going to attach to the structures within its name. So coraco is referring to the coracoid process, and acromial is of course referring to the acromion. Then we have the coracohumeral ligament, which is attaching to the coracoid process and to the humerus itself. And then our glenohumeral ligaments are going to attach from the glenoid cavity over to the humerus. And there are a couple different ones, just know them collectively for now. And we also see the tendon of the long head of the biceps brachii muscle sneaking in here, and it sits in that intertubercular sulcus. So that's going to creep up into the capsule to make its way over to that supraglenoid tubercle on our scapula. And the most joint stability is due to our rotator cuff muscles, which we're going to see a little bit better on the next slide. So here you can see some of your rotator cuff muscles. This one is subscapularis over here. And then we see posteriorly and extending over is your supraspinatus muscle. You have your infraspinatus muscle posteriorly there, and then your teres minor over here. So since this is kind of moving around, I'll also identify them over here in these two photos. We have subscapularis anteriorly, and by the way, this is a lateral view. So we're looking at the humerus over here, and most of these are inserting onto the greater tubercle, but the subscapularis inserts onto the lesser tubercle over here anteriorly, and this is kind of a lateral / posterior view. So there's that subscapularis inserting into the lesser tubercle. Now your supraspinatus, infraspinatus, and teres minor are all found posteriorly and insert into the greater tubercle. So here's another view: supraspinatus, infraspinatus, and teres minor. So the way that I like to remember your rotator cuff muscles is that I remember the term sits. So S-I-T S. You just have to make sure you remember this is teres minor and not teres major. And you can remember that we sit on the greater tubercle, but we don't sit on the greater tubercle, since subscapularis goes onto the lesser tubercle. So what they're doing is they're kind of inserting all around this, this humerus at the proximal end so that we can hold the head of the humerus into the glenoid cavity. So it is going to fuse along with the articular capsule as it provides the stability. And I wanted to show you some other views of the shoulder. So here is a lateral view where the head of the humerus has been removed. And now you can kind of see that glenoid labrum a little bit better over here surrounding the glenoid cavity. And then there's that tendon of the long-headed biceps brachii that moved into the capsule and is going to insert onto that, or I'm sorry, originate from that supraglenoid tubercle on the scapula. And now for a clinical view, we said that the shoulder joint is commonly dislocated because of its instability. So that separation that we have between the acromioclavicular, within the acromioclavicular joint, dislocation is seen over here, and this is illustrated here where we see those ligaments have been torn at the acromioclavicular joint, and here we see a ligament torn at the corticoclavicular ligament. So this is what the shoulder normally should look like, how your acromioclavicular joint should look normally, whereas here you can see that it has kind of lifted up, and we are able to distinguish that acromial end of your clavicle a little too well here. You'll also find that this patient would have pain if they abducted their arm more than 90 degrees. We can also have glenohumeral joint dislocations that would occur when a fully abducted humerus was struck hard. So you can imagine this would happen in a lot of sports, especially within basketball or volleyball, where you are reaching up often. And the shoulder is going to often appear that it is flattened or squared off, and the humeral head will move anterior and inferior to that glenohumeral joint capsule. And we can have an anterior dislocation or a posterior dislocation. So I wanted to show you the difference between these. This photo down here is showing you an anterior dislocation. So you can almost see that rounded area where the humeral head is. And then here you could see a posterior dislocation, again, with that rounded head, this time facing posteriorly. And now let's move on into the elbow. Remember that this was a hinge synovial joint, and we have two articulations taking place here. We have the humero-ulnar joint, which takes place between the humerus and the ulna, specifically at the trochlear notch of the ulna that would articulate with this trochlea here on the humerus. And then we have the humero-radial joint, where we have the capitulum of the humerus articulating with the head of the radius. And I just put this photo in here to show you the shape of the trochlear notch that would be extending posteriorly to the trochlea here. Both of these joints are going to be enclosed with a singular articular capsule. So you could see that here where we have yellow showing our joint capsule. And our elbow is going to be pretty stable because we have that articular capsule that is very thick and surrounds both of the joints, and our bony surfaces of the humerus and the ulna are interlocking together very closely. We also have multiple strong ligaments here that are helping to reinforce this articular capsule. We have our radial collateral ligament, and anytime I see that word collateral, I just think of like parallel fibers to the joint. So that's what we have here on the radial side, is these parallel ligament fibers going from the humerus down to the radius. This is helping to stabilize that lateral surface and extends around the head of the humerus, which would be right underneath here. And then we have your ulnar collateral ligament. So this is the same thing. We see these parallel fibers connecting from the medial epicondyle of the humerus down to the coronoid and also the olecranon of our ulna. And this is going to stabilize this medial side of our joint. Now we don't see it in this lateral view over here because it's on the other side, but we do see the radial collateral ligament really beautifully over here. Now I know this is a little confusing because it does look like that these fibers are inserting into the ulna, but actually this ligament starts from the lateral epicondyle and is reaching down and goes underneath a common extensor tendon, which we don't see here, and blends with our next ligament, which is the annular ligament that is on our radius. So this was named because the word annular means ring, and this surrounds the neck of the radius and binds the head of the radius to the ulna. And you could also see it in this illustration up here, how it's kind of wrapping itself around that neck of the radius. And here's another view. This time we have a medial view of the elbow, so we could see that wonderful ulnar collateral ligament over here extending down from the medial epicondyle. And then this is a medial sagittal section, so you can see the trochlear notch of the ulna here and that trochlea of the humerus and the articular cartilage and that synovial cavity, all beautifully illustrated here. Now for a clinical view, something that is pretty common is subluxation of the head of the radius. Whenever we see that term subluxation, it means that we have an incomplete dislocation. So this example is for the head of the radius, and sometimes when you pull onto a child's arm, you get some traction. That head of the radius can be pulled out of the annular ligament. So here is how it is normally placed, and when you pull on their forearm, that head can kind of peek down, or you can even have a little tear to that. And what can happen is as that head and neck shift down, we can have an entrapment of that annular ligament between the capitulum and the radial head. And of course that can be painful. It's usually going to happen in children who are less than 5 years old, and that annular ligament is thin in there, so the radial head is not fully formed, and that's why it more easily kind of pulls out. So in order to treat this, a pediatrician might place the forearm in supination and maneuver that radial head back into the annular ligament by kind of just twisting it and popping it back in. I actually have a former colleague that did this to their own child when it happened to them. They were swinging their daughter around in circles by grabbing their arms, and then all of a sudden she had a subluxation of the head of the radius and he just popped it back in. Amazing, right? What a super dad. And so subluxation can of course take place in several different joints. You can see it here taking place in the knee. Actually, a lot of dogs have this happen to their knees where that patella is just going to shift a little bit out of place. And this is a nice view as to how that patella can shift over. And then if it shifts over too much, then we would call that a dislocation of the patella. Now on to our hip joint, where we are going to have articulation between our head of the femur and the acetabulum of the os coxa. We are also going to see a labrum here. We call this the acetabular labrum. That's going to make the socket deeper, and you could see this here in the cadaver version. Once again, this is made up of fibrocartilage, and it's also going to allow this hip joint to be more stable by deepening the socket, and in turn is going to make it less mobile than our glenohumeral or shoulder joint. And here is just an illustration that we're going to reference to in the coming slides. First, we want to talk about how we support the hip joint. We do have a nice articular capsule. We're going to have ligaments in place and muscles. This articular capsule is going to extend from the acetabulum here to our trochanters, so lesser and greater trochanters, and it helps to enclose that femoral head and neck. We also have these retinacular fibers over here on each side that are going to be kind of connected to that articular capsule, and it reflects around the femoral neck. We'll also have some reticular arteries here, which aren't pictured, but they help give most of the blood supply to the femoral head and neck. Now let's talk about some intracapsular ligaments. First, we have our iliofemoral ligament, so named because it's attaching from the ilium over to the femur, and this is providing support for the anterior articular capsule. We also see part of it over here in this posterior view. And next is our ischiofemoral ligament, so named because we're attaching to the ischium here and extending to the femur. And this is going to only be located posteriorly. Remember that the ischium is located posteriorly as well, so that makes sense. And then anteriorly, we are going to see our pubofemoral ligament, which is going to be a triangular thickening of the capsule's inferior region. And we'll only see this anteriorly because our pubis is anterior. And these become taut when our hip is extended. And another special ligament is found inside the capsule is our ligament of the head of the femur, which is also known as ligamentum teres. This is just a small ligament from the acetabulum that fits onto that fovea of the head of the femur, and it doesn't really provide stability, but it does contain an artery that supplies the head of the femur, and you could see it in this cadaveric view as well. Now for a clinical view, when we have a fracture of the femoral neck. When we fracture the femur, it's often incorrectly referred to as a fractured hip, when really it's just our femur that's being fractured. So the first type is an intertrochanteric fracture, where we're going to have extracapsular fractures, and it's usually in our younger and middle-aged individuals. If we have a subcapital fracture, capital is referring to the head, right? So it's right below the head. And this occurs within the hip articular capsule, and usually in more elderly people that have osteoporosis. It may also result in tearing of those retinacular arteries there, which if we tear those arteries, we're not getting blood supply to that area, so it can develop into avascular necrosis, meaning that tissue is going to die in this region because it's not getting its blood supply. Now on to our knee joint. This is the largest and most complex diarthroses joint, and it's primarily a hinge joint, although we do have some other slight rotation movements and lateral gliding when the knee is flexed. And we have two separate articulations here. We have our tibiofemoral joint that's taking place between the condyles of the femur and the condyles of the tibia here. And then we have our patellofemoral joint that takes place between our patella and that patellar surface of the femur. Our knee joint is going to have an articular capsule, so that would be kind of surrounding all of this region in here. It's not really pictured in this illustration, but it's enclosing all of the medial, lateral, and posterior knee regions. We also have this group of quadriceps femoris muscles that form this tendon that moves on inferiorly and passes over our knee's anterior surface and surrounds the patella. And this tendon makes the patella a sesamoid bone, a bone encased in tendon. And then we continue down as the patellar ligament. This is also the ligament that is tested for reflexes. So we'll talk more about this when we discuss our peripheral nervous system. And it is attaching down here at the tibial tuberosity. Next we have our fibular, or I'm going to give you three names here. It's the fibular collateral ligament, lateral collateral ligament, or peroneal collateral ligament. And this helps to reinforce that lateral surface of our joint and extends from the femur up here down to the fibula. And this is really helping to prevent hyperadduction. So if this tibia and fibula were to kind of swing in this direction, that would be adduction, right? So by having this ligament here, it prevents that movement. Now for our tibial collateral ligament, or another name for this one is medial collateral ligament. And that's because it's going to reinforce that medial surface of our knee joint here, and it extends from the femur down to the tibia, and is preventing hyperabduction. So by this ligament being placed here, it stops our tibia and fibula from swinging out in this direction. Now sitting on top of the tibia, we can't really see it over here, but you can see it in this view where some of those ligaments and the patella and tendons have been cut out of the way. We see our medial and lateral menisci. Menisci is plural, meniscus is singular, and this is deep to our articular cartilage of the knee joint. And if you look at the superior view of the tibia, so basically we took this femur out of the way and cut these ACL and PCL ligaments, which you see over there, we see that our menisci have a C-shaped fibrocartilage pad on top of those tibial condyles. And this helps to cushion between our articulating surfaces of the femur and the tibia. We'll see that it changes shape to conform to that articulating surface, and it's partially going to work to stabilize the joint medially and laterally. Now to those cruciate ligaments. Cruciate means cross, and that's because these ligaments cross one another. And once again, we're going to be deep to the articular capsule. So first we have our ACL, or anterior cruciate ligament. We could see just a small portion of it over here in the posterior view. And this ligament is going to extend from the posterior femur, specifically on the lateral condyle, down to the anterior tibia. So if I go back over here, you could see its placement to the anterior tibia over here. And this is working to prevent hyperextension and anterior displacement of the tibia. So if I were to pull on this tibia anteriorly or toward you through the screen, that would be anterior displacement. And of course, hyperextension would be the tibia swinging out toward you from the computer. And then our posterior cruciate ligament, or PCL, you could see portion of it here from the anterior view, but of course better seen here in our posterior view of the knee joint, and is extending from the anterior-inferior femur, so closer to our medial condyle here, down to the posterior tibia. And let's go back. There's the attachment here of our PCL on the tibia. And this is preventing hyperflexion and posterior displacement of the tibia. So now we of course need to talk about some clinical applications here of our knee ligaments and cartilage injuries. We can have a tibial or medial collateral ligament injury when the leg is forcefully abducted. So you could see that this ligament is torn here, so this leg is able to extend on out to abduct. And then if our lateral or fibular or peroneal collateral ligament is injured, that means that the medial side of the knee has probably been struck, which tore this ligament here. And remember, that is preventing adduction. We can have an ACL injury in which our leg is hyperextended. Here we can see that this leg has been placed under some torsion, where we have our femur rotating in one direction and the tibia and fibula rotating in another direction, which caused the tear over there. And then we can also have a PCL injury where that PCL is torn. And this is just an illustration showing you what a posterior drawer sign is. So a therapist or a doctor would put some pressure on the tibia to see if it slides back, and this is what's happening internally. If that PCL is torn, then that tibia would be able to move posteriorly. We can also have a meniscus injury due to trauma and or overuse, and sometimes we get what's called an unhappy triad, where we have injury of that tibial collateral ligament, a medial meniscus, and the ACL. So you can see here in this example, a hockey puck has struck the knee on the lateral side, causing the tear on the opposite side of the knee. And now we have reached the distal end of our body. I know this has been a lot of new joints that you all are learning, but we're in the home stretch here. We've got our tallow curl joint, tallow referring to the talus, and crurl referring to the leg. So we have the bones of the leg here. This is a modified hinge joint, and it allows dorsiflexion where we point the toes up and plantar flexion where we point the toes down. And we have two articulations within one articular capsule. So it's going to be between the distal end of the tibia and the talus and the distal end of the fibula and the lateral aspect of the talus here. We're going to see that having the placement of our medial malleolus and the lateral malleolus kind of capping off the sides or the lateral ends of the talus allows it to, or rather prevents it to stop sliding medially or laterally. And we have that articular capsule that is covering the distal tibia, medial malleolus, lateral malleolus, and the talus itself. So now let's talk about some of the ligaments that help stabilize this joint. We have this deltoid ligament here where we have those three extensions off that are binding the tibia to the foot on this medial side. And then we have it working to prevent over-eversion of our foot. Remember, that was when we took the lateral side of our foot and pulled it up superiorly. Then we have our lateral ligament over here, here, and here, where it's binding the fibula to the lateral side of the foot. And this is helping to prevent over-inversion, where we take the inner side of our foot and pull that upward. And this is going to be prone to strains or tears, which we're going to see on the next slide. And lastly, we have our anterior tibiofibular ligament and our posterior tibiofibular ligament. And these are attaching from the tibia to the fibula anteriorly, and we can see here attaching from the tibia over to the fibula posteriorly. Now let's talk about that sprain. This is going to happen when we have over-inversion of the foot, where we're going to get a stretching of those lateral ligaments we just talked about. We are not going to have any fracture or dislocation take place here, just a stretching or tearing of these ligaments. And then over time after that happens, you will get localized swelling and tenderness in the anterior inferior to lateral malleolus region. Another clinical view is of Pott's fracture, which we talked about back in chapter, I think it was chapter 7, when we discussed bone tissue and fractures. And this takes place when we have over-eversion take place. So you can see that this is happening to this football player over here, and the medial malleolus, it has avulsed off the tibia. So we do have a fracture taking place here, and the talus moves laterally and fractures the fibula. So you could see that fracture of the fibula over here. You might even have a little bit of pulling from that deltoid ligament causing that avulsion fracture.